We have no head-to-head comparisons. The approvals were based mainly on phase 1, phase 2 clinical trials, where we saw that the responses were highly durable, and we saw that the survival was worth to use these agents. And then we moved to the phase 3 area of trials, and presently we have 2 phase 3 trials, and we can say that the only one that has shown a statistically significant survival advantage is the Keynote 45. This trial compares in second line patients failing platinum-based therapy, pembrolizumab versus a standard of care chemotherapy. This trial did show superiority in terms of survival for pembrolizumab versus chemotherapy, superiority in terms of response rate, and also we saw that the quality of life was much better in patients receiving immunotherapy. The second trial was the IMvigor trial, where atezolizumab in a similar trial design was compared to chemotherapy. This trial, in fact, did show that atezolizumab did a great job, so it did the same that we saw in the phase 2 trials. The median survival was 11 months, but for whatever reason, because there was a selection in patients for the primary endpoint, that those were patients enriched for PD-L1 staining, the chemotherapy survival curve did much better, and then in this trial, based on this primary endpoint, there was no statistically significant differences in terms of survival comparing chemotherapy versus atezolizumab. Despite that, atezolizumab is a drug that is working in patients with second-line bladder cancer and is approved for being used in this second-line setting. So based on level 1 evidence, we can say that the first option is pembrolizumab, but all the other agents, that is atezolizumab, durvalumab, nivolumab, and avelumab, are options for our patients.